Investigations. A quick and easy way to begin investigating a neck mass is with an ultrasound. Ultrasound can roughly define the consistency of the neck mass and which structure it arises from. For example, is it a thyroid swelling or a lymph node enlargement? CT scan can be used for more detailed imaging than ultrasound because it creates 3D pictures by putting together multiple images from different angles, and can also tell us the condition of the structures surrounding the mass, such as the mass encroaching surrounding muscles, blood vessels, etc. The CT scan can be used to image the head region, which could reveal a previously undetected primary lesion that may be causing lymph node enlargement in the neck. CT angiogram may be used to highlight any pathology of the blood vessels. Other imaging options include MRI and PET scans. PET scans are especially useful when trying to find the primary cancer site in the case of malignant neck nodes. Besides imaging, tissue diagnosis can be obtained by fine needle aspiration cytology, FNAC, of the mass. It is not recommended to go directly for an open biopsy of a neck mass, especially if there is a suspicion of a malignancy. FNAC can generally differentiate between a neoplastic and an inflammatory neck mass, but does not give sufficient histological detail. Sometimes the FNAC could be non-diagnostic and may have to be repeated. However, it should still be the initial step for tissue diagnosis. If the FNAC detects a neoplastic lesion, the next step might include a bigger biopsy sample, such as a core biopsy or even open excisional biopsy. This would provide a bigger sample for more detailed histopathological analysis, including immunohistochemistry. Blood tests include complete blood count. Raised white blood cell count could indicate an infection. Pancytopenia could indicate lymphoma. If the neck mass arises from the thyroid, then thyroid function tests are necessary to check for any underlying hypo or hyperthyroidism. Differential diagnosis. Based on the patient's history, physical examination, and investigations, the physician could reach the appropriate diagnosis. The differential diagnosis can be classified based on whether the mass is midline, for example, thyroid mass, or lateral, for example, lymphadenopathy. Whether it is superficial or deep. Does it appear to be a congenital lesion, such as thyroglossal duct cyst? Is it neoplastic, such as lymph node malignancy, lymphoma, or salivary glands tumor? Is it an infection, such as Ludwig's angina? Or is it a systemic disease, such as tuberculosis? Other diseases include laryngecele, head and neck metastases, hemangioma, and cat scratch disease. Management. The specific management of the neck mass would depend on the underlying disease. If a neck mass appears to be lymphadenitis and is present for less than 3 weeks, it is recommended to start the patient on a course of antibiotics. If there is no response to antibiotics, or the neck mass persists for more than 3 weeks, then a detailed workup should be done. Lymphoma would require chemotherapy after its proper grading. Tuberculosis would require anti-tuberculosis therapy, which is a prolonged course of certain antibiotics. Non-functioning thyroid masses may require thyroidectomy. Cancer cases should be discussed in multidisciplinary team meetings, MDTM, to decide the appropriate management option for that patient. Treatment options could include surgery, chemotherapy, radiotherapy, or a combination of all three. In the case of secondary metastatic neck nodes, some further workup is required, including random biopsies from certain areas of the upper aerodigestive tract in search of the primary cancer site.